Hello and welcome to the Point of Care podcast. Today's topic is cellulitis and skin and soft tissue infections, or SSTIs. As an introduction, skin and soft tissue infections are infections of the epidermis, dermis, subcutaneous tissue, or superficial fascia. Cellulitis is the acute spread of an infection along the dermis or subcutaneous tissue. The diagnosis of cellulitis is largely clinical. Staph and strep group A are the most common pathogens due to the infiltration of the skin after disruption of the skin barriers due to a cut, bite, or something similar. As a checklist, when admitting someone with a concern for cellulitis, think about the ABCs. Is the patient septic or unstable requiring pressors or the ICU? As a chart check, look for prior infections, previous antibiotic use, IV drug use, or whether the patient is immunosuppressed. Admission criteria for a patient with cellulitis include failed outpatient PO treatment, systemic symptoms, and concern for a necrotizing infection. Things that you might ask about include the date started, the focal and systemic symptoms, whether there's purulence, and the patient's risk factors, which we'll talk about more later. Things that you can't miss include gas gangrene, necrotizing fasciitis, a septic joint, or a DVT. The initial treatment you should consider are PO versus IV antibiotics, usually cefazolin if you're not concerned about MRSA. Otherwise, you should be giving vancomycin. You should take pictures of the initial rash and draw margin lines to track progress. As an intake, ask about the date that the symptoms started. Ask about focal symptoms including pain, erythema, warmth, tenderness, edema, and whether there's a concern for abscess. Also ask about systemic symptoms including fevers, chills, sweats, and altered mental status. Ask the patient if they've noticed any purulent drainage coming from any open wounds. Ask about insect or animal bites. Ask about general risk factors including trauma, stasis, edema, diabetes, previous radiation to the site, IV drug use, and whether the patient's immunosuppressed. MRSA risk factors include previous MRSA infections, a hospital encounter in the last 8 weeks, IV drug use, penetrating trauma, if the patient's on dialysis, has HIV, if they're an athlete, if they're a prisoner, if they're in the military, or if they live in a long-term care facility. Pseudomonas risk factors include neutropenia, trauma, and post-op. As an assessment, take all that prior history into account, including infections, antibiotic use, IV drug use, immunosuppression, and the timing. Think about their systemic symptoms. Look on exam for erythema, warmth, tenderness, edema, whether it's poorly versus well demarcated, if there's purulence, lymphadenopathy, necrosis or crepitus, pain out of proportion to your exam, and your neuroexam of the limb, looking for strength and sensation. Data you should be looking for include a white count, sending wound cultures if you're concerned about a resistant organism, and an ultrasound to assess for an underlying abscess. The etiology and differential diagnosis of cellulitis includes a septic joint, necrotizing fasciitis, DVT, gout, contact dermatitis, stasis dermatitis, erysipelas, superficial thrombophlebitis, angioedema, bursitis, erythema nodosum, pyoderma gangrenosum, sarcoid, graft versus host disease, calciphylaxis, zoster, and erythema migrans, to name a few. The ones that we mentioned you can't miss include septic joints, necrotizing fasciitis, and DVTs. For a workup, of course, usually send a CBC, a BMP, and LFTs. You should only send a blood culture if there's systemic signs or symptoms of an infection or if the patient is immunocompromised. You should get an ultrasound to consider an underlying abscess, and only send a culture for an IND, again, if there's systemic symptoms or risk factors for a resistant organism. You can get a CT scan of the area if there's a concern for necrotizing fasciitis, pyomyositis, or osteomyelitis. When it comes to treatment, for antibiotics, if it's strep, you can give cefazolin or ceftriaxone. If it's MSSA, you can give cefazolin or nafcillin. If it's MRSA, you'll need to give vancomycin or linezolid. And if you're concerned for neck fash, you can give Zosyn or cefepime and clindamycin. You'll usually treat anywhere from 5 to 14 days, depending again on severity, the size of the infection, and the location. When it comes to narrowing your antibiotics, if there's no purulence, you can give Keflex or clindamycin if you have a penicillin allergy. If there is purulence or an abscess, after it's been drained, you can usually narrow to Bactrim or doxycycline. As supportive care, tell the patient to rest, trial ice packs, and elevate the affected extremity. Some pearls. Purulent infections are more likely staph, and MRSA is more common than MSSA in the inpatient setting. If it's non-purulent, it's most likely strep. If the patient is experiencing symptoms bilaterally, you should strongly consider other diagnoses besides cellulitis. Blood cultures and wound cultures have very low yields and are not routinely obtained unless the patient has systemic symptoms, is immunosuppressed, had a bite, or recurrent cellulitis disease. Erythema may worsen initially when you start antibiotics, but should start to improve within 72 hours. Some associations you should keep in mind. Gas gangrene is associated with C. perfringens. Dog and cat bites are associated with Pasteurella. Human bites are associated with Eikenella and oral anaerobes. Freshwater exposure is associated with Ehrlichiosis. Saltwater is associated with Vibrio vulnificus, and neutropenia is associated with Pseudomonas. The Emergency ID Net study suggested that MRSA was the most common identifiable cause of an SSTI among patients who present to the ED in 11 different U.S. cities. Among those patients, 95% of them were susceptible to clindamycin, 100% was susceptible to Bactrim, and 92% were susceptible to a cycline like tetracycline or doxycycline. You should consider the ALT-70 score for cellulitis. Things that will give you points making it more likely to be cellulitis and the need for inpatient treatment include asymmetric, age greater than 70, a white count over 10, and a heart rate over 90. If you remember nothing else, cellulitis and SSTI are most commonly caused by staph and strep. They're usually treated in the outpatient setting, but reasons for admission include failed outpatient PO treatment, systemic symptoms, or an immunocompromised state. If it's a purulent infection, it's more likely MRSA. If the patient has bilateral disease, you should strongly consider other diagnoses such as stasis dermatitis. You can't miss gas gangrene or necrotizing fasciitis, which requires immediate surgical intervention, as well as vancomycin or clindamycin. That's all for this episode. Check out pointofcaremedicine.com to see the templates we discussed, as well as the pearls, literature, and links to other resources.